All right. Well, thanks everybody. So good to see you all here today. We're going to continue our discussion on sodium and water handling that we have had over the past couple sessions. And we're specifically now getting into the edema formation that we see in nephrotic syndrome. And I I think most of us have been taught underfill and overfill theories, but I'm not even so sure about that. I don't remember being taught either when I was a student, and that probably was because I slept through most classes. But I don't remember even as a resident talking about it too much until I really started reading and diving into some human literature. So I think it's a good idea to bring this up and review because it still is an area of active exploration and more data is coming in, and we're still not 100% certain on everything, but I think we know a lot more now based upon what's been figured out in the last 5, 10 years than what we did in the decade before that. So let's start with which one should we start with? Let's do the longer one because the other one is just an editorial, which kind of reviews a lot of the stuff. But I did think it had some other comments that were nice that were there too. So let's go through the pathophysiology of edema formation in the nephrotic syndrome. So why don't we start this like we start all of our sessions? Is there any areas that people struggle with that you had questions about that you want to start the discussion off with? If not, we'll just plow through it. All right, plowing it is. Okay, so we know that patients with proteinuria can develop edema, and we think of that edema being part of the nephrotic syndrome, although probably not the only reason for some of those patients to develop edema. And what is quite curious is that you can have two patients with the same UPC. They both have a UPC of 8, and one patient has no edema and another patient does. And why is that? Why do we see the difference being unrelated to the magnitude of their proteinuria? It means that there has to be other mechanisms that are happening. And I don't think we even have a good explanation for that just yet. But in those patients who develop edema, there have been a couple of schools of thought to explain it. And I'll jump back very quickly to the editorial because I like the way that they started their abstract because it was a simple description that was convenient, but unfortunately was not true. And so they started their abstract in saying, "Blessed were the days when it all made sense and the apparent mechanism for edema formation nephrotic syndrome was straightforward. Kidneys lost protein in the urine, which lowered the plasma oncotic pressure. Thus, fluid leaks into the interstitium, depleting the intravascular volume. You have the RAS system that is activated, sodium and water retention, and it perpetuates the cycle." The end. And that has been likely the predominant mechanism of edema formation that has been taught. And I would anticipate, probably for many of you, that might have been the predominant mechanism for edema that has been proposed. For the education that you guys had, I guess you can think back to vet school, but as well as more advanced training, was that the predominant mechanism of edema? Was that the working hypothesis that had been proposed to you folks, or was the overfill hypothesis the predominant one? I'm just curious to see what you might have been taught.
The first one.
Okay.
Yeah, the underfill.
Yeah,
Maybe.
I'd say that's the same. And then when the albumin wasn't low enough, we'd kind of throw up our hands and say vasculitis, question mark.
I don't know. It's got to be that plus something else that we don't know. I love vasculitis. Like, I feel like vasculitis is the cause of so many edemas because you can never prove it or disprove it. You're like, probably vasculitis. It's like Bartonella in my mind. Yeah, so I was the same way. Underfill was what was taught, and it wasn't until I started reading through Rose and Brenner and Rector that I really even had encountered this overfill hypothesis. And the overfill hypothesis is that we have a primary renal sodium retention, and that leads to volume expansion and edema. And that had been recognized even before patients became hypoalbuminemic. So there are older studies showing in edematous patients that have, presumably because of their proteinuria, they still had a normal albumin concentration, but their urine sodium excretion was very low. Their urine sodium concentration was low, their urine output was low, and this led to the beginning of this overfill was just there's sodium retention. We don't know why, but that sodium retention is there, and it might occur earlier than hypoalbuminemia. So this article is going to dive into both of those and the limitations of the evidence we have to support the different mechanisms for edema, which I thought was a really nice review. It includes Starling's formula here. So we have J, which if we remember from our dialysis kinetics, J is a term for flux. So that's the movement of water between compartments. So that's the movement of fluid from the capillary bed to the interstitium in this situation is equal to the filtration permeability constant. That's essentially your clearance factor. That's your K. And that's going to be dependent upon the permeability of your vascular bed. It also would be accounted for partly by surface area, which they didn't really talk about here, but specifically in the glomeruli, remember your mesangial cells that hold one capillary loop to the next are contractile. And if they contract, it might shrink the surface area available for filtration. And if they expand, they might allow recruitment of additional capillary loops. So surface area is one thing that is often also accounted for in that filtration permeability coefficient, but they didn't really bring that up too much. And then we have the gradient between the capillary and the interstitial hydraulic or hydrostatic pressure, minus the difference between the plasma and the interstitial oncotic pressure. And then they also introduced the factor of rho, which is the reflection coefficient. And if you think about it, most proteins are negatively charged. If you have a membrane where it has lots of exposed negatively charged molecules, that's going to cause those proteins to bounce off. So it's going to repel negatively charged molecules like proteins, where if you have more of those negatively charged molecules that are covered, then it's easier for those proteins to sneak through. So that's rho, that's the reflection coefficient. And they do talk a little bit about how the conductance, that those factors are accounting for the numbers of pores, the size of the pores, and a lot of those factors are not easily identifiable, that we can't measure them. I do think it's important for humans. One of the main ways that they develop diabetic nephropathy is hyperglycemia causes a change in the actual filtration kinetics of your glomeruli, and that's what starts the process of diabetic nephropathy. Not something that we see in our patients because they don't live long enough to develop it likely. And then they talk a little bit more about that that protein reflection, where a rho of 1 means it's completely impermeable to proteins and 0 means it's permeable, and that is not a fixed number, that it can change in response to inflammation, and there are some things that can increase it, some things that can decrease it, and we usually, because we can't measure them very well, we kind of collectively put the filtration coefficient and the protein reflection coefficient together, and we refer to that as permeability. So we could have vasculitis that could affect either of those things. Vasculitis could affect the permeability, the pores become larger, the membrane becomes thinner, or it could change the exposed amount of protein so that the protein reflection is actually less. We don't really have ability to quantify that, but the end result is still a change in vascular permeability. So Starling's law is central to the movement of water across any capillary bed, and important here when we're trying to figure out why our patients might have edema. So what I liked about this paper is it took each of those components of Starling's law and really tried to break it up into what evidence do we have for that component being a large player in the formation of edema in our patients with nephrotic syndrome. So let's kind of work through it. Any questions, any comments so far? Anybody have before we start getting into the individual things?
Yes, I didn't understand very well how hyperglycemia can increase the conductance of the filtration membrane.
Yeah, I don't think that it is completely understood, because the mouse models that exist for diabetic nephropathy are not great to begin with. So the models that are present will cause progressive glomerulosclerosis and lead to similar features of diabetic nephropathy, but it's not the same thing. So it's a very hard disease to study, and millions and millions and millions of dollars have been put forth into these models that fail to completely represent it. So I don't think that that's completely understood in humans, how hyperglycemia molecularly leads to changes in that permeability and the ability for proteins to leak out. We just know that it does at this point. So I don't think I have a good answer for you, because I don't know if that answer necessarily exists at this point. Any other questions or comments? All right, so let's start going through those features. So the first and the big one is the change in the oncotic pressure. And this is the crux of the underfill theory. And that's low plasma albumin, and albumin being the main determinant of your colloidal oncotic pressure. So low albumin, low COP. That reduces that gradient between the oncotic pressure between the interstitium and the intravascular space. The interstitium has a higher oncotic gradient, and that's going to pull water in. So that is the main theory behind it. So now we go through some of the evidence, and actually it's been shown, and this is represented in figure 1, that hypoalbuminemia is accompanied by a parallel decrease in interstitial albumin. And this has been shown in animal models, as well as I think maybe even some human data, because there is a condition, it's pretty rare, but there is a condition of analbuminemic people where they don't make albumin. They don't. And amazingly, they don't have edema. We'll come back to that in a second. But they looked at the model of those analbuminemic rats. And through micropuncture studies, they determined there was no difference between that colloidal oncotic pressure gradient between their plasma oncotic pressure and their interstitial oncotic pressure compared to normal rats that had a normal albumin concentration. And in fact, as figure 1 shows, as time went on after a model of injury, and I think this was in this was a starvation, a protein starvation model where these rats were not given protein at all, that they had decreases in their plasma oncotic pressure, which is this top graph here, but that was mirrored by, and in fact, a greater decrease in their interstitial oncotic pressure. So this shows us from a model standpoint that as we have reduction in our plasma oncotic pressure, the interstitial oncotic pressure is reduced as well too. One of the big things I bring up over and over again to my interns when we talk about edema and fluid accumulation is we don't see pulmonary edema in patients who have subcutaneous edema, ascites, everything that's not due to heart failure. We don't typically see pulmonary edema when it's just due to a hypoproteinemic state. And Rose covers this a little bit in his book really nicely, but it's because in the lungs, you have really large transcellular spaces between your pulmonary capillaries and your pulmonary interstitium. And any change in the oncotic pressure there very, very rapidly produces the same change in the interstitial oncotic pressure, so that gradient is remained. And that's why we don't have that edema that forms in the lungs when your albumin is low. But this evidence would suggest, well, this might happen in many other tissues, just like what's proposed in the lungs as one of the safety factors. So that really pulls the rug out a little bit of that theory that the gradient is shifting, and now the interstitial hydraulic pressure, the interstitial oncotic pressure is higher and pulling water out. And so they do write and cite that this has been shown not only in these animal models, but also been shown in people. And of those people with N-albuminemia, they don't make albumin. 43% of them had no edema, and 38% had only mild edema. And that really undermines the role that albumin might play, because the evidence we have is reduction in your serum albumin concentration is going to be mirrored by an equal, if not greater, reduction in your interstitial oncotic albumin. And they go through a couple reasons for why that might occur, and that's the washdown and the washout. So the washdown is where if you do have initially hypoproteinemia and that interstitial oncotic pressure is in fact higher, that's going to pull more fluid from the intravascular space to the interstitial space, and that's going to dilute the proteins that are there. It's going to reduce that interstitial oncotic pressure. That's the wash down. It dilutes it. And then the second part is, as you now increase your interstitial fluid accumulation, that is going to stimulate more lymphatic drainage, and the lymphatic drainage can actually cause more proteins to get pulled out in those lymphatics, both reducing your interstitial fluid, but also reducing that interstitial protein, and that's what's called the washout phenomenon. So the combination of those two likely cause that initial reduction in your serum albumin concentration to produce a very similar reduction in your interstitial oncotic concentration as well too. Let's see, I'm trying to think. The only other thing I want to point out here before we maybe take a second just to stop and digest that is they do comment on the study where they compared people with proteinuric kidney disease, nephrotic syndrome, versus those that just had chronic kidney disease. And they found that both in CKD patients and nephrotic syndrome, you both have expansion of the intravascular and interstitial space, but that was really only seen in the nephrotic patients to be only in that interstitial space rather than their serum, their intravascular component also having volume expansion. And they gave some theories for that. The big reason they said that the nephrotic syndromes didn't have intravascular volume expansion was likely due to that wash down and the wash out components. Okay, why don't we pause there for a second? Is everybody cool with that? Questions? Does that make sense? Does that not make sense to people? Because I think that's an important concept that really undermines hypoalbuminemia contributing to our edematous state that we see in patients. So let me just pause there for a second, making sure everyone's okay. Everybody good? Makes sense?
I think it makes perfectly sense when you read it in the way they explain it, the step by step of how can you come to a simultaneous drop in both intravascular and interstitial albumin, and makes perfect sense.
Yeah, I think that's a good story that's supported by evidence. That's the complete opposite of what we all were taught, which is a fun scenario when we find our teaching to be based upon not much evidence and just whisper down the lane. Okay. All right, let's keep rolling. So they bring up the concept of what about a very rapid reduction in plasma albumin? What if you have an acute nephrotic syndrome patient? And they're referring mostly to patients with minimal change disease. We do see minimal change disease in our patients. We don't see it very commonly. I would say we get maybe 2 or 3 a year through the biopsy service, so it's pretty rare. Happens a lot more in people, happens a lot more in children. So young adults, teenagers, and even people under the age of 10, minimal change disease happens. And this is where, if we look at it's called minimal change disease because on light microscopy, everything is normal. The glomeruli are totally normal. Cellularity is normal. Capillary loops, open, nice and clear. There is no evidence of obvious disease. It's not until we look at electron microscopy where we see there is fusion of the podocyte foot processes, and there are ultrastructural changes that are there. When we do immunofluorescence, we have negative staining. Electron microscopy also fails to identify any immune complexes that are there. And that's minimal change disease. Humans, it's very responsive to steroids. They usually go into remission quite quickly. I think it's 80 or 90% go into remission with steroids. In veterinary medicine, more of the patients have had minimal change disease associated with some type of drug therapy, often chemo drugs or some other medication, but it's usually drug related. We have had some cases that seem to be idiopathic. So they're bringing up, well, what if you have an acute minimal change disease episode that causes acute hypoalbuminemia? What could happen? And they bring up canine plasmapheresis here, which I thought was very fitting for our patient population. And they quote several studies that are showing that plasmapheresis, where you're removing plasma and you're replacing it with an isotonic crystalloid, can cause hypoproteinemia in dogs. And I think we routinely see that, especially if you're only doing plasma exchange with 30 to 50% of that volume, the replacement volume being plasma. Even if you do 100% plasma, remember the albumin concentration of your fresh frozen plasma is probably 2 because of the additional ACDA and things that are there. I've tried to do TPE with 100% plasma as the replacement solution to improve a patient's hypoalbuminemia prior to surgery for a splenectomy and a kidney biopsy, and it failed to produce a difference. And it's partly because I thought the albumin was going to be 3.5, because that's what the albumin of a normal dog might be. And in fact, it wasn't, because it's diluted out with everything else. You have some albumin that's degraded. So even in a normal TPE treatment for a toxicity, you'll usually see that their plasma protein concentration is less after the treatment. So the studies they're citing here, moderate hypoproteinemia, a total protein of about 4.5, does increase the extracellular fluid volume, but no change in blood volume, and there were no changes in the RAS, where continuing that to produce more severe hypoproteinemia, the total protein about 2.5 now, does decrease the plasma volume and the blood volume and causes increase in renin and aldo and positive sodium reabsorption, so evidence of more significant activation of that volume balance. So this is saying acute hypoproteinemia, and this would probably be pretty quick within several hours, I would imagine, can cause edema formation and intravascular volume depletion. But I think a good question is, do we see naturally occurring disease have such a rapid decrease in their albumin concentration? Probably not. The patients probably have a more gradual onset, even if that is over the course of 2 days, 4 days, 5 days. That's a lot different from 2 to 5 hours that we could get it with TPE. So maybe with very acute hypoalbuminemia, and this might be true for a patient with an acute liver injury, they were exposed to some type of hepatotoxin that had synthetic failure of their liver, maybe that could be the same case. They didn't raise that as a possible example, but I think clinically we might see that with bad amanita or alpha toxin or something like that. Okay, now let's move on to the changes of the hydrostatic pressure. Now this is difficult because there is really not a great, well agreed upon, easily performed test of intravascular volume. We really rely on looking at the RAS activity as a marker of hypovolemia. We look at physical exam if they are showing evidence of dehydration or hypovolemia. And then lastly, we can use radioisotopes of albumin to evaluate it, but that's obviously a challenging thing to do, which is not readily clinically available. So that's a good caveat to begin with, that assessing volume is difficult. Let's see. Some of the things that I highlighted here, and they did quote a number of studies, but some of the big things that I thought were important, that there was no correlation between blood volume and plasma renin activity or serum albumin and blood volume. So we would think that as blood volume would go down, your PRA should go up. As your albumin goes down, your blood volume should go down. And that was not found in these people with nephrotic syndrome. I think most had minimal change disease as well too. Minimal change disease is the most common cause of nephrotic syndrome in people. So it's just what you're going to see in most of the studies. Further studies looking again at people and whether they had signs of hypovolemia or not. Patients in both groups had, with hypovolemia symptoms, had higher levels of hormones, norepi, renin activity, and aldo. Fractional excretion of sodium was lower than their patients who were not having any symptoms, despite having similar magnitudes of proteinuria. And that neurohormonal activation, so activation of the RAS, your sympathetic nervous system, was associated with hypovolemia, and those with the most significant activation of those systems had the lowest albumin. So it does suggest that there is a connection between severe hypoalbuminemia and hypovolemia, but that is not a consistent feature that's seen in every patient. Further studies showed that looking at the ability of these kidneys to respond to antidiuretic hormone, arginine vasopressin in this example, that there was a volume-mediated stimulus that was driving the release of ADH in nephrotic patients, and they had a slightly different regulation and response to ADH than patients did who were not nephrotic. So again, proteinuric patients might have some activation of ADH and therefore water retention for reasons that are not completely understood. It was shown that they have this altered response curve, but they don't actually have a good explanation for why patients with nephrotic syndrome have altered response to ADH overall. So the summary of this, they found that most edematous patients with nephrotic syndrome actually have a normal intravascular volume. Some have expanded intravascular volume, And the minority of those patients actually had depleted intravascular volume that would be supportive of that underfill theory. So if they're intravascularly depleted because of the hypoalbuminemia, the fluid being lost, then we should see that the edema could be corrected with restoration of their volume. And as we're getting into here, affecting those neurohormonal responses doesn't actually play a big role. So in nephrotic patients that had sodium retention, so they had low fractional excretions of sodium, which should tell us that that could be an underfilled state, that they're nephrotic, but they're reabsorbing all the sodium maybe because they're intravascularly depleted. And that's going to be through renin being activated. Remember, decreased perfusion to the kidneys is going to cause decreased GFR. That lower filtration is going to cause the intraluminal concentration of chloride to go down. The macula densa sees that low concentration of chloride, and the macula densa stimulates the release of renin from the juxtaglomerular cells. Renin cleaves angiotensinogen into Ang1. Ang1 becomes Ang2 via ACE, and Ang2 causes sodium reabsorption from the proximal tubule. It stimulates aldo release, which is going to pull sodium and water in the distal tubule. So the net effect would be water retention. Because of sodium retention, the urine sodium should be low. Okay, so we're all in agreement there. So in these patients that they're nephrotic with a high renin and low sodium concentration, that if we give them an ACE inhibitor like captopril, it didn't change their sodium balance or cause weight loss, despite lowering aldo. So the drug did something, it lowered aldo, but we did not see that it changed the fluid balance of those states, of those patients. So it's likely to suggest that the edema in these patients was not driven by the RAS system. There's been conflicting results on whether there's an agreement between the aldo concentration and the urine sodium concentration. Some studies found that there was, some found that there wasn't. And other studies have found that you can have edema without having any increase in aldo levels, saying it's probably RAS independent. So because that's not a consistent feature, it might mean that some patients could have activation of the RAS, blocking it doesn't help their edema, and other patients are going to have edema that's going to be RAS independent. And if there's that much variability, then you're probably not going to have the RAS be a consistent or significant feature of edema in the nephrotic syndrome. And that's what this paper has agreed upon as well. Okay, another break there. Everyone okay with the RAS? Questions about that aspect? All right, let's keep rolling on. So moving on to the sympathetic nervous system. The sympathetic nervous system, and specifically we're talking about the nerves going to the kidneys, can cause changes of afferent and efferent resistance and can lead to the release of renin, which then can cause more Ang2 and aldo. In fact, for resistant hypertension in people, it was thought of emerging therapy, and I think it's now mostly abandoned, but I'm not 100% sure of that. But one of the interventions done for resistant hypertension in people was renal denervation. They would actually go in surgically and cut the sympathetic nerves going to the kidneys, and patients could have improvement in their blood pressure. And I don't know exactly why it's not commonly done. Obviously, it's an invasive surgery. There are many risks associated with it. But I don't know if it was replaced by just better drug therapy or what, but you still might come across renal denervation as a mechanism of managing severe and refractory hypertension. So there's some evidence that there could be activation of these renal sympathetic nerves, which can affect the volume expansion that we see. But even after renal denervation of some of these mouse and rat models, we found that they were still becoming edematous despite denervation, suggesting, okay, the renal nerves are probably not big factors there as well too. And then we get to ADH, that patients with nephrotic syndrome have higher ADH levels than those that are controlled. And if they were underfilled and had hypovolemia, then they should have a stimulus for ADH, because their baroreceptors would see that there's decreased stretch, decreased pressure, and that's going to stimulate the release of ADH to pull in water. Remember, you have two major physiologic stimuli for ADH: decreased effective circulating volume and hypertonicity, hyperosmolality. And then there's a lot of other causes: nausea, pain, many drugs can do it. But physiologically, those are the two that we worry about. So in those patients that we thought would be underfilled, and that would be why their ADH level would be higher, if you give those patients albumin, which is going to expand their volume, it does decrease their ADH level. So that suggests that these patients could have some magnitude of hypovolemia that's there, but that hasn't always been shown in every study that's been performed in mice. And they mention this, and they come back to this model a number of times, this puromycin aminonucleoside, or PAN nephrosis. And puromycin is a drug that causes glomerular injury in rats, monkeys, and men, I believe. I don't think it affects mice. I don't think it affects dogs and cats. So it's a model that's used to cause glomerular injury, increased glomerular permeability, and proteinuria. And so that's the model that's there. Let's see. So in a model of injury where this was a slightly different one, this is using adriamycin, and this I think was where maybe one kidney was affected and one was not. Yeah, the kidney that was given adriamycin, so each kidney was isolated. One kidney was injured with adriamycin, the other was normal. The injured kidney was resistant to atrial natriuretic peptide, where the normal kidney did respond. So proteinuria could cause an abnormal response to ANP. Remember, ANP, when we have volume expansion, should cause a natriuresis, hence a diuresis to follow, and that was unable to be performed. So if the proteinuric kidney cannot excrete that extra sodium under the influences of ANP, does it have another mechanism that's causing and fighting for increased sodium reabsorption, such that the ANP signal can't overcome to cause excessive sodium secretion? And that's probably the case. So there's evidence that there are some animal models where there's decreased responsiveness to ANP, but there are others that showed conflicting results. So it doesn't seem like that is a major influence on the formation of edema. Now we get to the big game changer, and that's primary renal sodium retention. And this is something which has, again, long been proposed, that under some unknown mechanism, the kidneys just start reabsorbing all the salt, and it causes volume expansion. We don't know why, but that's been shown simply through reduction in urine sodium concentration. So a model of a unilateral nephrosis, and this is again with that PAN, where we have one nephrotic kidney, one normal kidney, that the nephrotic kidney that was proteinuric and reabsorbing sodium, the normal kidney that didn't have any proteinuria handled sodium normally. So that tells you that it's going to be an intrarenal mechanism, that if it was a systemic and neurohormonal mechanism, if it was because of the RAS system, that the other the other kidney being exposed systemically to the same levels of renin, Ang1, Ang2, and aldo should have sodium reabsorption despite not being proteinuric. And they didn't show that. So the affected kidney had altered sodium handling, normal kidney had normal sodium handling. Therefore, it has to be something within the kidney. So they showed a number of things that were present. One is that in the cortical collecting duct, the basolateral sodium-potassium ATPase. So remember, that's along the bottom of your tubular epithelial cells. That sodium-potassium ATPase is what keeps sodium out of the cells and pulls potassium in, and it favors that gradient. That there is more of that activity in cats that were having nephrotic syndrome. So if there's more basolateral activity, it means you're pulling more sodium out of the cell. That favors the electrochemical gradient for sodium to move into the cell. So if you're pulling it out of the bottom, more can go on the top, and more is going to get pulled out of urine into circulation. And so that's on the basolateral side. Now the apical side, in order for sodium to get from the tubular lumen into those epithelial cells, is through the epithelial sodium channel, or the ENaC that we call it. And it's been shown that when you have nephrotic syndrome, you have more ENaCs that are being made, and there's increased targeting and movement to that apical surface. So these are channels that are made intracellularly, and then they're sent up to the apical surface of the cell. And that's increased when we have nephrotic syndrome, and aldo helps to do that. So it seems like maybe aldo could cause this increased number of your apical sodium channels, your ENaCs, and then you're having an aldo independent mechanism for the increase in the basolateral sodium potassium ATPase. Now, when they did a model where they did an adrenalectomy in these rats, they found that it prevented the increase in the apical targeting of ENaC, but it didn't prevent nephrotic syndrome from developing. So what does that say to me? Okay, it means that aldo is important for a greater expression of these ENaC receptors. But even when you impair that, the normal amount of receptors that are there are still sufficient to potentially cause too much sodium to be reabsorbed. So aldo can make it worse, send more of those ENaCs up. But even without aldo, you have enough that you could still develop edema. And then if we block those ENaCs, if we inhibit them with an epithelial sodium channel inhibitor, that's amiloride, that's the drug, it prevents sodium retention and therefore edema formation, where if we give those patients something like spironolactone, which blocks aldo, it doesn't occur. So, summing all this up, the increase in those ENaC channels that we see is because of aldo, but the development of nephrotic edema is not dependent on aldo. That aldo can make it worse, but without aldo, I'm breaking my computer, we have enough of those receptors that we can still have edema that forms. Sorry, ENaC's got me very excited. So that really tries to narrow in that maybe this could be the area that we need to be concerned about. So we've talked about that those ENaC channels are somewhat controlled by aldo. ADH does have a role there as well too. And those channels have multiple units, and they're often present, but they're in a closed state. And you have to cleave one of those subunits, and when it's cleaved, you now have an open channel that can bind sodium and send it in. So it's the cleavage that allows that to be open. And what's been shown is that that activation is a normal process that happens inside the cell, and that's how we have active ENaC channels. But when we have other enzymes that might activate those ENaCs, we can have those receptors that might normally have been present in a closed fashion become open. And what's been shown is that in the urine of proteinuric rats, we find that there is plasmin and plasminogen. And the plasmin present in that urine can activate those channels by removing that gamma chain, which actually causes it to remain closed. So one study showed that plasmin can do that, and plasmin was normally there in the urine of proteinuric rats. And that is because plasminogen can be filtered from the glomerulus, and urokinase present within urine can cause proteolytic cleavage of plasminogen into plasmin. And so if we remember, and I don't remember off the top of my head, so I am Googling it right now, but if we look at the molecular weight of plasminogen, it is 92 kilodaltons. Remember, albumin is about 67 to 69 kilodaltons. So it's not that much bigger than albumin. So any change of permeability within the glomerulus that's going to cause albuminuria likely could include the loss of plasminogen. And if we have plasminogen in urine, that becomes activated by urokinase, which is always there. Remember, urokinase was the first thrombolytic drug that was discovered. And now we have much better thrombolytics. Went urokinase, then streptokinase, and now we have things like tissue plasminogen activator, TPA. But urokinase, which is always there in urine, activates that plasminogen to plasmin, and then plasmin can cleave that gamma chain of your ENaC. It activates it, and then we have sodium reabsorption. So it shows that this ENaC channel is probably one of the predominant mechanisms for sodium reabsorption. And that mechanism is just shown here. So here we have plasminogen that's filtered into urine, gets cleaved by urokinase into plasmin. Plasmin takes away that gamma domain. We have this open ENaC. That's going to get more salt inside the cells. And then remember, the basolateral side, the ATPase activity is also increased. So we pull more in and we can send more out. That means we're going to reabsorb more salt and therefore reabsorb more water. So this is the overfill. This is what's been demonstrated, and this happens earlier than hypoalbuminemia in most patients with nephrotic edema. So the ENaC is really where we need to be focusing a lot of our attention in terms of how we might treat these patients. Lastly, they go in to talk about the changes in vascular permeability. Again, here's our vasculitis type scenario, that you can have multiple patients, again, with that same magnitude of proteinuria. One might have edema and the other doesn't. So why might be the case? And maybe there are changes in vascular permeability that can account for it. They went into a number of different papers which kind of said some changes could be present in some patients, but not in all. So the capillary permeability could be one factor that is there. Something very hard to measure and hard to intervene with, but maybe that could be one factor of why the dog with the UPC of 10 is edematous and why this dog with the UPC of 10 is not. I think that's an important differentiation to make before we as a profession intervene. Because the dog with the UPC of 10 that was just given 4 liters of fluid in 12 hours could be edematous because we also then just sodium loaded the patient as well too. That might have reduced the COP acutely, and we might have multiple of these mechanisms that could be activated. And then this paper closes kind of summarizing what was found, showing that the previous evidence that we have has shown that abnormalities on the change in hydrostatic pressure and change in interstitial pressure to explain edema have not been perfect. And that hypoalbuminemia, and therefore low plasma oncotic pressure, does not seem to be a likely cause of edema in most patients because that interstitial oncotic pressure also decreases parallel. There might be some degree of vascular permeability, whether that's true vasculitis or just some increased permeability that could be there. But proteinuria can cause this avid sodium retention, and it does seem like the most substantial evidence we have for edema formation in these patients is the overfill theory due to activation of your ENaC channels, causing more sodium to run into the cells, more activation of the basolateral sodium-potassium ATPase, getting that sodium into your vasorectal capillaries. Doesn't seem like this process was dependent upon the RAS system. Excessive ADH might be present, but is probably just a contributing factor, and that's kind of what we're left with. And then they kind of close just giving a little bit of information about amiloride, which, remember, that's that ENaC channel antagonist. And they say that it's not likely that that would be sufficient to prevent that volume expansion because it's so late in the nephron, but it might be something that could be used, especially in combination with furosemide. And then they do say that, well, even though this is the strongest evidence we have, there are patients that have a genetic activation of the ENaC. So patients, humans with Little syndrome, they have a spontaneous activation of those ENaC channels, and they have sodium retention and hypertension, but they're not edematous. So it is not the only explanation for why we might have edema if we have people with the same activation of that apical transporter who lack it. So we're still figuring out, but this is certainly where we have the most evidence. And there has to be something else that contributes to it that we're still working. Whew. All right, big summary there. And I think the second paper, which was just a very small editorial, the reason I wanted to include this is not only did it summarize those big points, which were great, but it brought up some of the limitations. I think we already have discussed the limitations. They had good evidence for the limitations of underfill in the first study, in the first paper. It repeats it. It also goes into problems with the overfill theory of just being the most simplest one to explain it as well too. And so I thought that was just a nice complementary read. We don't have to go through that in any greater detail unless there are specific questions about that. But we're coming to the end of the hour, so let's open it up. That was a ton of information. What questions do you guys have? Anything that did not make sense in refuting those aspects of underfill and the introduction and the evidence we have for the overfill theory? What questions do you have?
I don't really have questions because I thought the papers did a really good job, and actually really enjoyed that second editorial a little bit more because it summarized everything really nicely. But I just really enjoyed some of the experiments that they kind of touched on in that second paper, and I just thought they were very well done and kind of really simple in a way, but very effective because of how simple they were. Like I particularly enjoyed how they took the urine from those minimal change patients, in and out of remission, and proved that that could change the ENaC status on those renal cells. And I just thought that was kind of amazing. It's like simple things like that that are so easy to do, that can just prove a point so easily, but that we often fail to do. And I just thought it was a really good example of that.
Yeah, I agree. Really simple ways to prove it. Obviously, things that hard to do in terms of actually doing a clinical study and intervention, but a very simple question that they're answering. Well, can we take the urine when they're nephrotic and not, and does it produce different effects? And it does, because there's probably different amount of these serine proteases. It may be plasminogen and plasminogen 1, but there certainly have been shown to be others that are there as well too. The one thing I want to bring up, just to put that out there as well too. So the second paper did suggest that, well, if this was so true, then why shouldn't amiloride be the drug of choice for treating nephrotic syndrome? And they cite that there's really only one study that we have in people that was evaluating it. There are individual case reports, and in this study they used furosemide as well too. And this editor does state that their personal experience is that they've not been impressed with it, but they've never used it by themselves, amiloride by itself. They've also always used it with Lasix. And if you're giving it with Lasix, then you're going to flood that distal tubule with sodium, and you might minimize the effects of the ENaC inhibitor if you're also giving way more substrate that's there. Now, we have used amiloride in patients. We've used it as the only drug without using Lasix for treating nephrotic edema. I can't say I've used it enough to really be able to say how well it works. The dose is extrapolated. There's no dose in dogs, so we're extrapolating it based upon the milligrams per kilogram that a normal person gets. Seems to have been well tolerated. I think this is an area that we need to investigate more, and a drug that we need to use more of. I do get much more concerned about using a loop diuretic, as the IRIS guidelines suggest for treating edema, because I think those patients very often do not have adequate intake of nutrition and fluids and are probably more at risk of becoming volume depleted. Adding a loop diuretic onto that could potentially exacerbate that too. So we've been using amiloride more recently as the drug of choice to treat nephrotic edema. So I would propose, I think we have some good evidence for it and good justification. So the next nephrotic dog you see, it might be a drug that you want to turn to. And if you use it, let me know, because I would love to hear its efficacy, or if it didn't work, or the patient didn't tolerate it, because I don't think most vets are aware of all this evidence that's there. I don't think most vets are going to turn to amiloride. So unless we're starting to push the envelope and change our understanding, we're going to be stuck in the dark days of saying all the edema is due to hypoalbuminemia. And maybe dogs and cats are different. I'm sure they are in some ways, but the overwhelming evidence in people really minimizes the role of that hypoalbuminemia. So I'm curious to see how things go in the future. Do we have any other questions? Any other comments anybody have? Things that they're still struggling to understand?
Well, actually, as Matsuri was saying, it's very interesting. And as you said, we have been told differently about the edema theories. And I was looking that actually this mechanism has been around there for more than a decade. And after that, I was looking for if we have any assay or test for plasmin in the urine, because it could make sense that we could kind of follow up those patients to try to understand when and are they going to get fluid overloaded because of the sodium retention. I could only find one validation study for a test in humans in 2015. I'm not sure if we have something newer out there, if you think it might be interesting to look at, because we don't know if our patients actually have kind of the same behavior, or can we do something differently about that?
Yeah, I think that's a really good thought. And I think one of the ways that we might be able to look at it is when we submit biopsies, or even if we don't submit a biopsy and we perform SDS page on a urine, that SDS page test gives us all these different bands that are there. And we could potentially look at the bands that are most consistent with that 92 kilodalton size. So let's just take a quick look at, I just pulled up a completely random patient here, but here's a patient's SDS page. And look, they have this band here right at 97 kilodaltons. That probably could be plasminogen is there. And plasmin, because it's cleaved, is probably going to be smaller. So one other thing that could be done is you can actually take these gels and you can cut out the bands. And then you can send the bands out for essentially mass spec to see, well, what proteins are there in each of those bands. So it could be done. It absolutely could be done. And it would be really interesting to look at these SDS pages on dogs that had nephrotic edema and those that didn't, to see, even from a starting perspective, were their bands different? And we might not have as many biopsies in nephrotic patients because maybe owners are a little bit less likely to treat those, to do a lot in those patients because they tend to be sicker, but that might be there. So I think that would be a great question. Let's look at the database, compare nephrotic versus non-nephrotic patients, and even try to do a control. If we have a nephrotic membranoproliferative GN, let's get a non-nephrotic membranoproliferative GN as its comparison. If we have a nephrotic membranous, let's get a non-nephrotic membranous as its comparison and look to see if their electrophoresis patterns are different. And that might tell us maybe there's other factors. Maybe there's a different serine protease that's present in the urine of our patients that we need to take a closer look at. And if we can identify those bands, then maybe that's what we could potentially send out for mass spec. Which I think is a pretty cool idea.
Yes, I was excited after this paper. Thank you so much.
Yeah, of course. Well, I'll reach out to Jess and see if she has any idea on that. She is starting at Texas A&M, I think on Monday. So she's finally getting settled. So let's give her a big project the very first day that she's there. But I think it could be really cool. Yeah, exactly.
Yes.
We're going to reach out to her and see if she has any thoughts on it. And yeah, any other final questions, comments before we bring this session to a close? All right. Well, as always, thank you for coming and participating. I hope these sessions continue to be interesting. I will come up with some articles for next month. I will send that out with a link to this month's video, and I'll post it on the website. I'll send everybody an email once that's been done. Otherwise, we'll go ahead and stop the recording. Thank you guys for coming. Look forward to seeing you guys again, and hope you have a great rest of your week and weekend.